friends. I'll continue my discussion about reproductive medicine, and today I'll be talking mainly about the reproductive pharmacology, the various drugs which we use. So, of course, I'll be integrating all these also, whatever relevant to my talk. So, before I discuss, let me refresh your knowledge about reproductive physiology, without which you will not understand. A quick recap. We all know from hypothalamus come the GnRH that come to anterior pituitary, and that causes release of LH and FSH. Now in the males, LH acts on the testes and that causes production of testosterone, and this is converted into dihydrotestosterone by 5-alpha reductase, and ultimately this gets attached to the receptor. So-called androgen receptor complex is made, and ultimately they are the one which are androgen receptor responsive. They act on the genes having androgen responsive cells. This is what happened in the males. But what happened in females? In female, LH and FSH, they come and act the ovary. Ovaries secrete androstenedione and androtestosterone. This is a very, very important point. And these are converted into estrone and estradiol via aromatase. And these are going to act on the estrogen responsive cells. Estradiol is converted into estrone and estrone is converted into estriol. This is in brief about the physiology which you have read in my previous lectures, but I wanted to refresh your knowledge. Okay, this full screen is there. I hope you already have noted down, but still if not, then you can have quick time, you can note it down. With this background of basic understanding of physiology, various drugs that we'll be using in this pharmacology, they will be acting at one or the other steps in this flow chart only. Now let's talk about biochemistry. Testosterone is converted to DHT by 5-alpha reductase, and in the female, androgens are converted to estrogen by cytochrome P450 aromatase. Well, you can see this aromatase is there. Aromatase is the key enzyme in conversion of androgen to estrogen. It's a very, very important point. We'll be using this knowledge in the coming lecture slides. With this small background, we talk about pharmacology. The first is gozerlin and leuprolide. What are the mechanism of action? They are GnRH analogs. So when we use in pulsatile fashion, point to be noted, they act as a GnRH agonist. But when we use in a continuous fashion, the first initially they act as an agonist, but later on they become antagonists. Point to be noted, something very interesting to note. It is the pulsatile we use is a agonist, but when we use continuous, it becomes initially agonist, but later on antagonist. Why? How come? It down regulates GnRH receptor in pituitary. So now it decreases FSH and LH. Okay. So something very interesting pharmacology to remember. Now, the leuprolide can be used in lieu of GnRH. We use for uterine fibroid, endometriosis, precocious puberty, prostate cancer and infertility are some of the uses that we use, especially for leuprolide. Side effects are hypogonadism, decreased libido, erectile dysfunction, and some GI disturbance like nausea, vomiting, which are non-specific. But as far as reproductive biology is concerned or medicine is concerned, they are the one which are important side effect of this drug. Second drug is Digeralex. It is an antagonist, no startup flare. Since it's a pure antagonist, unlike the previous one where we had initially we have flare up, this no flare up. It's total break. Used in prostate cancer. Side effect hot flashes and liver toxicity are the two important side effects of this particular drug. Estrogens, various estrogen we use like ethinyl estradiol, DES, diethyl stilbestrol, mestranol. Very obvious how they are going to act since they are estrogen. So they are definitely acting on the estrogen receptor only, as the name goes, and we already have read in the basic concept that we have estrogen receptor cells are there. Where we use in ovarian failure or wherever a hypogonadism is there, we tend to use estrogen. Menstrual abnormalities are there that contain a lot of difficulty, irregular menstruation. In such cases, we use this drug. Hormone replacement therapy is very, very important in post-menopausal women. It really not only remove the discomfort of the menarche, but it also help in the treatment of osteoporosis also. Okay. Well, in the men also we use in androgen-dependent prostate cancer. So we have a role in both male and female also. So we use in males also. Adverse effect, endometrial cancer chances are much more. It's a really matter of concern. Bleeding in post-menopausal women. Clear cell adenoma of vagina in female exposed to DES, diethyl stilbestrol in utero, risk of thrombi, especially deep vein thrombosis. So, endometrial cancer, bleeding, adenocarcinoma, and risk of DVT is the big problem. That's really a matter of concern in these patients. Contraindication, very, very ER receptor positive breast cancer. It's a very, very important side effect. History of DVT, again, a very common contraindication, important contraindication. And tobacco use in female above 35 years. There are important contraindications where the estrogen should not be used at all. Okay. Now, selective estrogen receptor modulator, clomiphene. It is antagonist to estrogen receptor in hypothalamus. Okay, if you look into this diagram, Okay, clomiphene blocking negative feedback. So it prevents the normal feedback inhibition and increase release of LH and FSH from pituitary. Definitely. So they are now more and more LH and FSH will come from pituitary gland, and that will stimulate ovulation. Let again look into this. We know GnRH is going to cause LH FSH. So normally we have a feedback, a negative feedback, and that negative feedback will not be there. It means every time more and more LH and FSH will be there, and that will lead to stimulate ovulation. We especially use in infertility due to PCOS is a very, very important condition where we use this drug. Clomiphene is a very important drug to induce ovulation in PCOS, polycystic ovary syndrome. Side effect, hot flashes, ovarian enlargement, multiple pregnancies, something very interesting. We are using in a patient where there's no child, but when we use it may be multiple gestation also. That means the lady is gifted with multiple children at one time. Visual disturbance can be there. Tamoxifen is an antagonist at the breast, very, very important point, but agonist at bone and uterus. So there are, because that means at different side it has got different action are there. So, but there's increased risk of thromboembolic event, especially in smokers. It can induce endometrial cancer also. But we use to treat and prevent recurrence of ER/PR positive breast cancer. Point to be noted that we are using for ER and PR positive breast cancer, but we definitely we can induce endometrial cancer, and it can induce thrombotic phenomena, deep vein thrombus. Raloxifene is a other drug. It's an antagonist at breast and uterus, but it is agonist at the bone. Point to be noted, again having two different type of action at two different places. Again, increased risk of thromboembolic phenomena, but there is no increased risk of endometrial cancer as compared to tamoxifen. Point to be noted very carefully. Thromboembolic phenomena can happen, but endometrial cancer chances are not that. Primarily, we used to treat osteoporosis, especially in the postmenopausal female. We all know very well that the postmenopausal female, the problem of osteoporosis is very, very high. In such cases, it is a good drug to be used. Aromatase inhibitor are anastrozole, letrozole, and exemestane are the three drugs. And definitely we know the basic mechanism of action of aromatase is it converts androgen to estrogen. So when we'll be using this inhibitor, this conversion of androgen to estrogen will not be there. So that will lead to reduce estrogen level. So we use in ER positive breast cancer in postmenopausal female because they are going to reduce estrogen levels. Hormone replacement therapy is a very widely asked question throughout the world. We use to prevent menopausal symptoms like hot flashes and vaginal atrophy. Osteoporosis, so there are two important uses. This is the universal question. Why we use for osteoporosis? Because they increase estrogen and they can decrease osteoclastic activity. We know very well osteoclasts are the bone resolving cell. They are the bone resolving cell. So they prevent the bone resolution. The bone integrity is maintained. Side effect: unopposed estrogen replacement therapy increased risk of endometrial cancer, and so that's why sometimes progesterone are added in this. Possible increase of cardiovascular risk also can be there. Progestin, there are so many progestin we use, the names are given in front of you. Okay, so we know very well that estrogen and progesterone are the two main hormones which regulate menstrual cycle also. Okay, well, let us see, and they are also part of oral contraceptive also. So how do these progestin we use? They act at the progesterone receptor, definitely. Estrogen act at the estrogen receptor, and progesterone, they act at the progesterone receptors. They decrease the growth. They increase vascularization of endometrium. They thicken cervical mucus. In fact, this is the one use. In fact, in pregnancy also, when the lady conceives, the increased level of progesterone is there from corpus luteum. So that progesterone thickens the cervical mucus. The advantage of this is now, if the more sperm come, they are not able to enter. So by this, it prevents the multiple pregnancies. So this line has a definite use by the progesterone, otherwise also. Use for as a contraception, forms pill, if we use in endometrial cancer, and we also use in abnormal uterine bleeding, what we write as AUM. So contraception, endometrial cancer, and we use in AUM bleeding, abnormal uterine bleeding we use. Now we have a term called progesterone challenge. Presence of withdrawal bleeding exclude anatomic defect. That means you are giving progesterone and you suddenly withdraw and bleeding occurs. That is very clear. that there is no anatomical defect, because in anatomic defect withdrawal bleeding will not be there, especially Asherman syndrome and chronic anovulation without estrogen. Very, very important point. This is like a golden line to remember. Should not forget this line. Then we have anti-progestin like mifepristone and ulipristal. They are the inhibitor of progesterone. Definitely when we say they are antagonist of progesterone, so they are going to reverse the action of progesterone. Where we use termination of pregnancy, mifepristone is used with misoprostol. Very, very important point. Don't forget. Okay. And emergency contraception we use ulipristal. They are again very important use of so-called progesterone inhibitor. Combined contraception, progestin and ethyl estradiol, they are combined. Okay, ethyl estradiol. So definitely that's why we both estrogen and progesterone are there. We call them as combined contraception. They can be in the form of pill, what we call as OCP. They are available in the form of patch also, and they are available in the form of a vaginal ring also. Of course, OCP is a very commonly used method. Now, estrogen and progesterone combined, they inhibit LH and FSH, and they prevent estrogen surge also. Okay, so if there is no estrogen surge, it will lead to no LH surge. No LH surge will lead to no ovulation. So, no estrogen surge, no LH surge, or no ovulation. Rather, this is more commonly asked question. So, what you should remember that when we use this OCP, they prevent LH surge. And no LH surge will lead to no ovulation. I hope you remember the basic physiology which I took in the first lecture of reproductive medicine. I hope you have seen. If not, go and refresh your knowledge. Then you will understand this point much better. Now, progestin causes thickening of the cervical mucus. So they limit the access of sperm to uterus, the point I mentioned previously also. And they also inhibit endometrial proliferation. Now, endometrium is not proliferating. It will not support the implantation of the embryo. So this is one more mechanism by which it will prevent the implantation. Adverse effect: breakthrough menstrual bleeding, breast tenderness, then embolic phenomena, and hepatic adenomas are the important side effects. This is a very, very commonly asked question. Hepatic adenomas, not carcinoma. Point to note it. Contraindication: we don't use in smoker above 35-year female, because this is going to add to the cardiovascular event. Although cardiovascular events are less common in female, but when we are in smoker, they are much higher as compared to non-smoker. Okay, so those who are increased risk, what type of? Venous thrombosis, thromboembolic phenomena, VTE, vitritis, venous thromboembolic phenomena, same but here also, venous thromboembolic phenomena that can lead to pulmonary embolism, CAD stroke. Migraine is precipitated especially with aura. Breast cancer and liver disease, they are the ones which are contraindicated in this. We should not use because they are going to add on effect. Copper intrauterine device, very popularly known as copper T. Copper T is what it is implanted. It's a mechanical device which is implanted in the female genital tract. It produces local inflammatory reaction. It is toxic to sperm and ova. That means it is definitely going to have toxic effect on ova and sperm. It will prevent the fertilization. So it prevents fertilization as well as implantation. The biggest advantage is a hormone free. It's not going to disturb any hormone balance in the body. The biggest advantage. It's a long-acting reversible endocontraceptive. Biggest advantage, long-acting, reversible. That means anytime the lady want, it can get it removed, and that means a patient can plan for pregnancy very soon. It's one of the most effective emergency contraception, also very widely used. Well, the side effects are heavier or longer menstruation. With dysmenorrhea, patient can have pain during menstruation. PID, pelvic inflammatory disease, definitely the mechanism of action, it produces local inflammation, but that can go into more extensive, it can lead to more inflammation also. So that's why it is contraindicated in active pelvic infection. Very obviously, if infection is there, it is definitely going to cause exacerbation of the infection. Tocolytic drug, let's learn what the definition of this drug. They relax the uterus. So definitely they are going to relax the uterus. So they are very good drug to prevent abortion. Example are terbutaline, nifedipine, and indomethacin. Point to be noted. All these three drugs we widely use in other medical conditions, like terbutaline we use in asthma because it's a beta-2 agonist. Nifedipine is a calcium channel blocker. Everybody knows that is an anti-hypertensive drug. This for asthma, this for hypertension, and this is for an NSAID, non-steroidal anti-inflammatory drug for various inflammatory conditions. Well, where we use decreased contraction frequency in preterm labor. In preterm labor, we really want that the uterus contraction should be reduced. So we use this drug. Okay, so it allows the time for administration of steroid to promote fetal lung maturation. Remember, I'm talking about preterm labor. So when we give steroid, it's going to promote fetal lung maturity, and to transfer to appropriate medical center with obstetric care. Suppose the patient, of course, the preterm labor and a patient is in a small setup where we don't have any adequate arrangement for the fetal newborn care, then this should be shifted to the higher center. But when we use, they give us a time. So they are giving us a time to take action on the right. Okay, right time action should be taken. And after that, we talk about danazole. It is a partial agonist to androgen receptor. It's a synthetic compound. Okay, so it is going to partial agonist. We use in endometriosis and we use in hereditary angioedema. We use this drug. Side effects are weight gain, edema, acne, hirsutism, muscularization, decrease HDL, hepatotoxic, and it can lead to idiopathic intracranial hypertension. Well, look into this. It is an agonist at the androgen receptor. So now, having learned the mechanism, if you look into this, all these are the effect due to androgenic effect. So no need to mug up. There are also maybe little bit contribution by this positive androgen. Next drugs are testosterone and methyl testosterone. Well, they are androgen and they will be acting at the androgen receptor site. Simple. Where we use? We use in the treatment of hypogonadism, definitely. Promote development of secondary sexual characteristic, and they simulate anabolism to promote recovery after burns and the injuries. Adverse effect, muscularization in female, definitely the lady will have all muscular feature. It will lead to premature closure of epiphyseal plate, so that will hamper the growth, increase LDL and they decrease HDL. That means they are going to promote hyperlipidemia. Anti-androgen, the drug is finasteride. Well, we all know very well that testosterone is converted into DHT by a 5-alpha reductase. Now, this is a 5-alpha reductase inhibitor. So that's why it decreases conversion of testosterone to DHT. Where we use for benign prostatic hypertrophy, and we also use in male pattern baldness. Adverse effect are gynecomastia and sexual dysfunction. Definitely is an anti-androgenic effect. So definitely going to cause increased estrogenic effect, that is gynecomastia. Well, then we have drug like flutamide, becaltamide. So there are so many amides are there. Amides, amide, and amide. Okay. So they are non-steroidal competitive inhibitor of androgen receptor. Point to be noted, they are receptor inhibitors. The previous one was the enzyme inhibitor that we use for prostate carcinoma. Ketoconazole it inhibits steroid synthesis. So definitely that's why it we use in the treatment of in the Cushing syndrome also. It's used in PCOS to reduce androgenic symptoms. It can cause gynecomastia, and amenorrhea is a very commonly asked question. Okay, but point to note it, they are going to inhibit the enzyme desmolase and hydroxylase, and that's why they reduce steroid synthesis. So one of the key, in fact, it's one of the most widely used drug in Cushing syndrome. Temsulosin is a alpha-1 antagonist used in benign prostatic hypertrophy. It inhibits smooth muscle contraction. In other way around, it relaxes smooth muscle in the prostate, and that helps that allows the urine to go out by relaxing the smooth muscle. It is a selective alpha-1 AD receptor found in prostate, and we also know that alpha-1 blocker, they are in the peripheral vasculature also, but they are alpha-1B receptor, they are alpha-1A receptor, they are alpha-1B receptor. So that's why we primarily use this drug in benign prostatic hypertrophy. Minoxidil is a direct arteriolar vasodilator. Initially, this drug was developed for hypertension, but nowadays we got many good and better antihypertensive drugs. So we don't use it as an antihypertensive drug now. We use in androgenic alopecia, in male pattern baldness, it is used as a lotion or in the form of cream. That's the main use for minoxidil. Now, a quick recap of about last minute revision point, but all you have to remember. Testosterone is converted to DHT by 5-alpha reductase. Aromatase is the key enzyme that converts androgen to estrogen. Goserelin and leuprolide, they are GnRH analogs. Degarelix is GnRH antagonist used in prostate cancer. Estrogen are contraindicated in ER positive breast cancer, history of deep vein thrombosis. Selective estrogen receptor modulator is SERM. The drug example is clomiphene. It's an antagonist at estrogen receptor at the hypothalamus. Is used in the infertility due to anovulation, especially in polycystic ovarian syndrome, PCOS. Tamoxifen is an antagonist at breast, used to treat and prevent recurrence of ER and PR breast cancer. Raloxifene is an agonist at the bone, used to treat osteoporosis. Aromatase inhibitor via the example are anastrozole, letrozole, and exemestane. They are the aromatase inhibitor. We use in ER positive breast cancer in the post-menopausal females. Hormone replacement therapy, they are used to relieve and prevent menopausal symptoms. The menopausal symptoms are especially hot flashes. This is very disturbing for the lady. Vaginal atrophy, osteoporosis, increase estrogen, decrease osteoclastic activity. We have anti-progestin like mifepristone and ulipristal, and this we use to termination of pregnancy, mifepristone. That means this one drug which will induce abortion. So this is a drug for inducing abortion. It's also emergency contraception is by ulipristal is used as any emergency contraception also. Copper intrauterine device, what we call as copper T in the popular general term. It produces local inflammatory reaction. It is toxic to sperm and ova, so it prevents fertilization as well as implantation. Tocolytic drug medication that relax the uterus. Then danazole is a synthetic androgen that acts in the peripheral agonist at androgen receptor. Is a partial agonist. And testosterone, they are act at the androgen receptor. Anti-androgen is a finasteride, is example, is a 5-alpha reductase inhibitor. So it reduces conversion of testosterone to DHT. We use the treatment of BPH and male pattern baldness. Then we have amides. They are non-steroidal competitive inhibitor at the androgen receptor and used for prostate cancer. Ketoconazole we use in PCOS to reduce androgenic symptom. Otherwise, it's a drug that we use for Cushing syndrome. It causes gynecomastia, amenorrhea. Tamsulosin is a alpha-1 antagonist used in BHP because they relax the smooth muscle. They prevent the contraction of smooth muscle. Minoxidil we use for androgenic alopecia, male pattern baldness. Thank you very much. God bless all of you.